Margaret is a 50-year-old woman who works as a nurse at the Rehabilitation Center in Halifax, Nova Scotia. She lives with her husband in her home in Bedford, and they have 2 children who are currently away at university. Margaret loves working as a nurse and describes herself as passionate about helping others. She enjoys the nursing community at the hospital and finds her environment very supportive. She enjoys playing pickup basketball, cooking, and walking her cat. Margaret suffered a left-sided middle cerebral artery ischemic stroke 3 months ago. Since this time, she has been an inpatient in the rehabilitation hospital. She originally had lost almost all function in her right arm, with limited mobility in her right lower leg. She has made progress and is able to walk independently, but her right arm is still significantly impacting her occupations. Margaret was discharged from the rehabilitation hospital and is now seeing the community stroke OT. She is living at home with the assistance of her husband. The OT is seeing Margaret for the first time at her home. The OT sat down to talk to Margaret about her issues and her goals. Right now, Margaret is unable to dress herself. This is very important to her because she is only 50 years old and she feels very dependent on her husband. She finds that her right arm limits her to be able to dress herself and take care of herself. Also, she is unable to work. She loves to work because she is with her friends and it brings her a sense of meaning and belonging. She says she couldn't imagine a life where she wasn't a nurse. She describes it as being who she is. Her nursing friends are the ones she plays basketball with as well, so she is scared that if she can no longer play basketball and work, she will lose her friends. She feels very discouraged about the situation, and she really wants to get better so she is able to do the things she enjoys again. The OT collaborated with Margaret to come up with goals that she would like to accomplish by the end of them working together, which is around 6 months. Margaret would like to dress herself independently because it would place less burden on her husband. She would like to begin to work part-time as a nurse because she needs a sense of belonging again in her life. She also says how important being active is to her and would like to get back to playing pickup basketball with her friends. Using the Chedoke McMaster stroke assessment, the OT will assess Margaret's impairment and activity functioning post-stroke. This assessment is usually completed by an occupational therapist or physiotherapist to assess functioning post-stroke. This information will inform Margaret's interventions to obtain her occupation-related goals. The Chedoke McMaster stroke assessment is used to assess a client's impairment in physical activity and functioning post-stroke. The intended population is for clients post-stroke in acute, rehab, or community settings. There are 3 goals of the assessment. 1. Stage motor recovery to classify individuals in terms of clinical characteristics. 2. Predict rehabilitation outcomes. And 3. Measure clinically important changes in physical function. A part of this assessment can be found online. However, it does not include the entire assessment. The entire manual can be purchased at the link below, which includes the administration and scoring guidelines for $15. The theory that went into the development of this model is the theoretical framework of the Chedoke assessment. This theory has 4 main domains, with the first being physical performance following stroke. This domain includes physical impairments and disability of the body, pain severity, and impact on function. Within the second domain of measurement theory, there are 3 main purposes of clinical measures: to predict, to diagnose, and to evaluate change. The World Health Organization classification of disease consequences is the third domain, which classifies impairment and disability. The fourth and final domain is client-centered practice, which is based on the belief that active participation in rehabilitation processes is important to an individual's holistic health. All of these domains overlap to inform and create the Chedoke McMaster assessment. The Chedoke McMaster assessment takes 45 to 60 minutes to complete. It may not be feasible to complete the entire test in one session, but can be completed over 2 days. All equipment should be assembled ahead of time and is listed here. The Chedoke McMaster stroke assessment is classified into 2 parts: the impairment inventory and the activity inventory. The impairment inventory is used to determine the presence and severity of common physical impairments. It has 6 dimensions: recovery stage of the hand, arm, leg, foot, postural control, and shoulder pain. Shoulder pain is measured on a 7-point scale based on pain severity. The remaining 5 dimensions, including hand, arm, leg, foot, and postural control, are measured on a 7-stage scale. Each point corresponds to 7 stages of motor recovery. Stage 1. The affected part, limb or trunk, is flaccid. Stage 2. Spasticity is present, no voluntary movement is present. Stage 3. Active voluntary movement occurs without facilitation, but is only in the stereotyped synergistic patterns. Stage 4. Synergy patterns, or common reflexes, and spasticity is present. Stage 5. Full range synergy movements and complex combinations of synergies are possible. Spasticity decreases. Stage 6. Selective movements, but lacking strength, dexterity, or coordination necessary for normal functioning. Stage 7. There is no evidence of functional impairment. Activities and skill are at a pre-stroke level. Within each of the 7 stages, there are 3 tasks given to assess the client's motor function. If 2 tasks are accomplished at the stage where testing began, assess the 3rd task, but regardless of the result, move up to the next stage. In order to achieve a stage 7, all 3 tasks in stage 6 as well as 2 in stage 7 must be accomplished. Margaret was assessed 1 week post-stroke in the rehab hospital. She scored on her arm and hand dimension a stage 2. Her leg and foot was a 4 and her postural control was a 3. She also scored a 3 on her shoulder pain. Now she is being assessed by the community OT in the impairment inventory. The first domain assessed is postural control. The client will shift their weight from one hip to another, lifting the butt off the mat and returning to the center. This is stage 5, task 1. The client could not maintain balance and uses her hands, which is a fail. In order to see if the client can pass the stage, 2 more assessments are completed. Posture control, stage 5, task 2. The client is assessed to see if they can complete the task of standing up with equal weight bearing. Margaret could complete this task, which is a pass. Postural control, stage 5, task 3. The client is assessed to see if she could complete the task of stepping forward onto her weak leg and transferring her weight. Margaret could not complete this task because she could not transfer onto her weak leg. Margaret could only do 1 of the 3 assessments, therefore she's a stage 5 in postural control. The same process is repeated for the next domains, but we are only showing 1 of the assessments for each. Each assessment that is shown after this point, Margaret will pass. Arm domain, stage 4, task 3. The OT will ask Margaret to complete the task of supination and pronation of her arm, which Margaret completed. 2 more assessments were completed in the stage to measure arm function that are not shown that she did not complete, which are shoulder flexion to 90 degrees and extension and flexion synergy. Hand domain, stage 4, task 1. The OT will ask Margaret to complete the task of finger extension and flexion by making a fist, which she completed. 2 more assessments were completed in the stage to measure hand function that are not shown that she did not complete. These are thumb extension and finger flexion with lateral movement. Leg domain, stage 5, task 2. The OT will ask Margaret to complete the task of raising her thigh off the bed, which she did complete. 2 more assessments were completed in the stage to measure leg function that are not shown that she could not complete. These are extension and flexion synergy, hip extension with knee flexion. Foot domain, stage 6, task 3. The OT will ask Margaret to complete the task of eversion of the foot, which she does complete. 2 more assessments were completed in this stage to measure foot function that are not shown that she could not complete. These are foot circumduction and tapping of the foot 5 times in 5 seconds. Following the impairment inventory, the activity inventory will be completed. The activity inventory assesses the client's functional level, but not the particular way in which the task is accomplished. This inventory includes 10 gross motor function tasks and 5 walking tasks. A scale from 1 to 7 is used, from total assist being a 1, while complete independence is a 7. The scores are summed for both gross motor for a max score of 70 and walking for a max score of 35. The highest score possible is 100 points, where lower score means lower function. The scale from 1 to 7 is as follows. 7. Complete independence. 6. Modified independence. 5. Supervision. 4. Minimal assist. 3. Moderate assist. 2. Maximal assist. 1. Total assist. A task should only be attempted twice in the impairment inventory and once in the activity inventory. In her activity inventory in the acute hospital, she scored a total of 43 out of 100. In walking, she scored 13 out of 30, and in gross motor function, she scored 30 out of 70. The OT will now assess her activity inventory. Gross motor function task, 1 out of 10. The OT will ask Margaret to stay standing for 30 seconds. After this assessment, she received a 4, which means she can complete with minimal assistance. Gross motor function task, 2 out of 10. The OT will ask Margaret to transfer up and down from floor and standing. After this assessment, she received a 2, which means she can complete with maximal assistance. 8 other gross motor tasks were completed, which are not shown. Walking domain task, 1 out of 5. The OT will ask Margaret to walk up and down 1 flight of stairs. She scored a 3 on this assessment, which means she can complete with moderate assist. 4 other walking domain tasks were completed, which are not shown. The impairment inventory. Based on the 6 dimensions, we can categorize the affected sides into low, intermediate, and high functional levels in relation to occupation. Stage 1 and 2 results in low-level function, therefore we can expect a client to not be able to do their ADLs. Stage 3 to 5 results in intermediate function, where we can expect a client to not be able to do IADLs and have issues with balance and movements. Stage 6 and 7 show some problems with some small activities and occupations, with muscle weakness and spasticity that may hinder but not disable the client. The activity inventory. A score equal or less than 30 generally indicates the client would need extensive full-time care, therefore meaning they would require major assistance in all areas of self-care, productivity, and leisure. A client who scores 70 or above would usually indicate that they are ready for discharge to independent living in the community or are competent to live alone. Therefore, they would be able to independently complete self-care needs and be able to work towards returning to full productivity abilities. The general treatment method after this assessment will be exercises and activities that are appropriate to the stage of recovery based on each impairment: arm, hand, leg, foot, and posture control. In the pre-function stages, which are considered to be stage 1 to 3, the focus is on exercises. This is using a bottom-up approach at the beginning of stroke rehab. As voluntary movement improves, a shift towards functional activities is made, which is using a top-down approach by using occupation as means for improvement. Activities are generally intended to progress gross motor function, arm and hand function, and walking. Therefore, assessment will help OTs to focus on more functional related tasks as an intervention and to use occupation as a means in order to improve motor ability post-stroke. After reassessing Margaret, she scored in Stage 4 on hand and arm impairment, a Stage 6 in leg and foot, a Stage 5 in postural control, and a Stage 5 in shoulder pain. In her activity inventory, she scored a total of 71 out of 100. In walking, she scored 22 out of 30, and in gross motor function, she scored 49 out of 70. These findings relate to Margaret's OPIs of not being able to dress herself and her inability to work and participate in leisure activities. This is because Margaret's hand and arm function, which is impaired, is preventing her from doing her activities. By scoring as a Stage 4, she may have synergy patterns and spasticity that will prevent her from reaching above her head to put on a shirt, impair her from doing fine motor tasks as a nurse, and shooting a basketball. By being in Stage 4, she may have continued issues with dressing, like doing up zippers and buttons. Although she is independent in walking, she still has some motor issues in her leg and feet that will prevent her from standing long days as a nurse and running up and down the court. By being a Stage 5 in postural control, Margaret may not have good balance playing basketball and putting on pants 1 foot at a time. In her activity inventory, Margaret scored relatively higher than her previous assessment, indicating that she is improving with little concerns for her walking ability. Margaret averages a 5, which means she needs some supervision but not assisted. She will not be able to return to work right away, but can if improvements are seen in the future. As Margaret has shown improvement since her first Chedoke assessment, the suggestions would be to continue with therapy. This would include muscle strength in her upper extremity, increase postural control with balance activities, start low-impact basketball activities with slow activity grading, and fine motor skill training in her arm. In addition, education to her husband about caretaking strategies and techniques would be appropriate. We suggest volunteering in the hospital for 2 hours a week, and we can provide Margaret adaptive technologies to help with her dressing. The limitations of this assessment are, in the activity inventory, the arm function is not addressed, and thorough functional arm and hand assessment should be completed beyond the Chedoke assessment. In addition, this assessment is not supposed to be used until 1 week post-stroke, so there's no indication of a client's abilities prior to this. Another limitation is that this assessment takes a long time to complete, and there's many different sections and tasks. A client who may not have the energy may not be able to complete these and may do worse as the assessment goes on because of fatigue. The advantages to this assessment is that it can be completed in many different environments. The studies confirm that the CMSA yields both reliable and valid results. The CMSA can be used with confidence as both a clinical and a research tool that can discriminate among subjects and evaluate patient outcomes. The test has excellent test-retest reliability, which means it is good to use as a marker for seeing improvements after stroke. It focuses on occupation and functioning in relation to occupation, which gives the OT an idea of how to proceed with intervention. It is very thorough and in-depth, which gives the OT a good understanding of the client's functioning and abilities. The theoretical framework of the Chedoke assessment impacted the interpretive process through directing the focus of the assessment steps into the 4 theoretical domains. This allows the OT to develop a well-rounded interpretation of the results to relay back to the client in order to enable them in getting back to the activities they need and want to do. Having 4 theoretical domains to draw on rather than just one allows the OT to classify the results into each domain of either physical performance following stroke, measurement theory, WHO's classification of disease consequences, and client-centered practice. The neurological determinant of occupation is the underlying model of this assessment. This model impacts the interpretive process because Margaret's abnormal movement patterns were as a result of damage to the central nervous system due to her stroke. Overall, this is a very in-depth and lengthy assessment used for the stroke population. We believe that it is very helpful to get a good idea of the client's strengths and weaknesses in relation to their ability to do occupations. We like that it is able to be completed in many different environments and that it has standard scores so we can improve intervention. We would recommend it to be used as a measurement to indicate how well a person is functioning post-stroke. However, it should be used with caution if the client has attentional problems or issues with fatigue.